I just want to start by saying thank you so much to Dr. Kelsey Thomas, who is joining us today to speak on the topic of using sensitive neuropsychological measures to identify subtle cognitive decline. And I wanted to just give a little bit of background about Dr. Thomas. She is an assistant professor of psychiatry at the UCSD. And she's also a research health scientist at the VA San Diego healthcare system. Her interests and grants have focused on detection of subtle cognitive changes during the preclinical phase of AD using sensitive neuropsychological scores, including process scores, which appear useful for identifying early cognitive inefficiencies prior to frank cognitive impairment. So that is the golden ticket, and that is what we are all looking for. So Dr. Thomas and colleagues have examined how subtle cognitive difficulties are associated with cross-sectional and longitudinal AD-CSF, PET, and MRI biomarkers. And her studies that focus on the earliest cognitive changes associated with vascular disease have also looked at diabetes and the relationship between cerebral blood flow and early cognitive changes, which is these are all measures that our ADRC also gathers on our participants. But we have to exclude a lot of our participants because of contraindications for a lot of these biomarkers, and this biomarker data is really valuable. So it's really exciting to see research like the kind that you're doing that can help detect these changes at these earliest stages and kind of expand the field in that way. And as you mentioned in your bio sketch, you know, that's one of the reasons it's really important to do this work, because there are a lot of people who can't undergo an LP or who won't undergo an LP and who can't do those kinds of assessments in the clinical arena. So thank you so much for your work and for being here today. And with that, I will mute myself. Thanks.
Great. Thank you so much for inviting me. I'm excited to talk about some of this work. Hopefully it's not too repetitive for some of the people I see who have joined. But so I'll go ahead and just dive right in. And feel free, I can't see you very well, so it might be easiest just to hang on to questions to the end, but if there's something pressing, feel free to jump in. Happy to answer questions along the way. So in 2011, this figure may look familiar to people. The NIA and Alzheimer's Association work group formally introduced this concept of preclinical Alzheimer's disease, which is thought to be kind of this protracted phase in which people are performing in the cognitively normal range, but are starting to develop underlying Alzheimer's disease pathology. And it occurs in people prior to frank cognitive impairment associated with mild cognitive impairment and dementia. And in 2011, kind of within this framework talking about preclinical Alzheimer's disease, they did this staging scheme where subtle cognitive decline was introduced, but it was thought to always follow amyloid accumulation. So amyloidosis is stage 1, and then stage 2 amyloidosis plus neurodegeneration. However, work by my colleague Emily Edmonds previously showed that subtle cognitive changes do not necessarily follow this temporal sequence outlined in these guidelines. And she actually showed that neurodegeneration is often one of the first pathologies to emerge. And so Dr. Edmonds developed an initial criteria for subtle cognitive decline that was defined by people. So if people didn't meet criteria for MCI, but performed in the impaired range on 2 tests in different cognitive domains. So she operationalized this definition and then incorporated these subtle cognitive decline criteria into a new approach for staging preclinical Alzheimer's disease that was based only on the number of abnormal biomarkers, including subtle cognitive decline, amyloid, and neurodegeneration, but without regard to any prescribed temporal sequence. So her staging scheme is on the right, and the NIA Alzheimer's scheme is on the left. And so this is time to MCI or dementia. And so what you'll notice is that the patterns are very similar, but what you don't end up with in Dr. Edmonds' scheme is this arbitrary suspected non-Alzheimer's pathology or SNAP group. And these are the folks that may show neurodegeneration or subtle cognitive decline in the absence of amyloid. And so there's also a group that couldn't be classified using this scheme. And so what Dr. Edmonds' staging scheme really showed is kind of this more parsimonious approach. And so Brock and colleagues' work using neuropathological data suggests that there is, rather than these kind of discrete phases, there's likely overlap in the development of neuropathologic as well as cognitive changes in that preclinical phase of Alzheimer's disease. And it's really the sensitivity of the biomarkers and our instruments to measure them that's been responsible for some of the past findings, assuming that amyloid accumulates first. And so this is consistent with Dr. Edmonds' findings that, again, the pathogenesis may not occur in discrete stages. So for me as a neuropsychologist, what I'm thinking when I see this really cool figure of on the right here is that if the detection of subtle cognitive changes is really limited by the sensitivity of our cognitive tests, then it's really critical that we find sensitive measures of cognitive change that can be used either alone or in combination with Alzheimer's disease markers to improve detection of Alzheimer's disease. And so this is Edith Kaplan, probably one of the more influential figures in my work. And she was a neuropsychologist out of the Boston VA who championed the use of process scores as part of a neuropsychological assessment and an interpretation of findings. And so process scores, as she defined them, are behaviors that speak to the errors in approach by which an outcome is achieved. So often for us as neuropsychologists, this may be the total score on a neuropsychological test. So what are people's approaches? How did that total score end up to be what it is? And so just as a quick example, on the left, you have a word list with 9 items. And so let's pretend 2 patients were told this list and asked to remember as many of the words as possible. And patient 1 and 2 both recall 7 out of the 9 words. But as you can see, patient 2 also recalls or also has 7 intrusion errors, making their recall performance a lot less efficient and just looks very different from patient 1. However, in a research study, it's usually only the total score that is captured. So in this case, these 2 people would be performing exactly the same. So this approach of using these types of process scores is termed the Boston process approach and is widely used by neuropsychologists in clinical practice, but these process scores have really been underutilized in research. And the process score profile in Alzheimer's disease dementia is quite well established. So people with Alzheimer's disease tend to have a flat learning slope, increased susceptibility to both proactive and retroactive interference. They may remember words only at the end of a word list, have more intrusion errors and elevated false positive errors on recognition. And so while the Alzheimer's disease profile has been pretty well established, very few studies have examined process scores in cognitively normal or preclinical AD older adults. And so I thought I saw Mark on the call, so I'm gonna throw back to some of his work that happened decades ago, supporting the notion that process scores. Sorry. And so this study on the left here showed that older adults with a family history of Alzheimer's disease had poorer learning, a greater recency effect, and made more intrusion errors than older adults without a family history. Mark also showed that cued recall intrusion errors independently predicted progression from cognitively normal to Alzheimer's disease. And so really since the 90s, this type of work hasn't been very prominent, even for neuropsychologists. And so these studies again supported the notion that process scores from a wordless memory test may be able to capture early cognitive change or inefficiencies before any objective impairment on neuropsychological total scores. So the first study I want to highlight aimed to determine the added value of wordless memory process scores to predict progression to MCI and Alzheimer's disease after adjusting for a number of known Alzheimer's disease risk factors in the model. And so these were the process scores that we investigated. So these are from the Ray Auditory Verbal Learning Test, which is quite similar to the CVLT. However, the words are not categorically related in any way like they are on the CVLT, but it's a 15-item wordless learning and memory task. And so the participant is read a list of words 5 times and is then asked to recall as many words as they can after the list is read each time. And then a different word list is read, so the interference list. Then participants are asked to recall as many words from the original list as possible, and then are again asked to recall the words after a 30-minute delay. So these process scores listed here have been previously shown to be impacted in Alzheimer's disease. So intrusion errors are that we define as the total number of non-target words that were said. And then learning slope measured the rate of learning across trials 1 through 5. Proactive interference measures to what degree previous learning inhibits new learning. And then retroactive interference measures to what degree new learning inhibits recall of information that had been learned previously. And so first, when we compare those individuals who remained cognitively normal over 5 years to those who progressed to MCI, we found group differences in that the group that progressed to MCI had more intrusion errors, a flatter learning slope, and a greater degree of retroactive interference. Then when we looked at progression to MCI, results showed that intrusion errors were a significant and unique predictor of progression, even after adjusting for a number of other predictors in the model, including total neuropsychological scores, cerebral spinal fluid and genetic susceptibility markers of Alzheimer's disease, demographic data, depressive symptoms. So those were all included in the model, and intrusion errors predicted progression above and beyond those variables. So these are just Kaplan-Meier curves showing that with an increase in the number of intrusion errors, there was faster progression to MCI. And a similar pattern was found for progression to mild dementia, though of course fewer people transitioned from cognitively normal to dementia within 5 years. So the next question for me was, can these process scores be used to help to define the construct of subtle cognitive decline? And so as a reminder, these subtle cognitive decline criteria are those that my colleague Emily Edmonds developed using neuropsych total scores. So if someone didn't meet criteria for MCI, but they had impaired neuropsychological total score performance in 2 different cognitive domains, then they would be this original definition of subtle cognitive decline. And we've added the OBJ, objectively defined subtle cognitive decline, to distinguish it a little bit from the acronym used for subjective cognitive decline. So you'll see this throughout my presentation. So as time went on, we've now called this objective subtle cognitive decline. And so I wanted to see if I could stage this objective subtle cognitive decline criteria using process scores as an early marker. And so we incorporated the wordless process scores into an early stage definition characterized by 2 impaired process scores, or 1 impaired process score and 1 impaired total score. and then a later stage subtle cognitive decline, which is the previous Edmonds criteria. And first, I can say that adding in the process scores to the definition did improve the sensitivity and overall ability to identify individuals who go on to progress to MCI or dementia. And then we looked at available cerebral spinal fluid Alzheimer's disease markers. So amyloid, the p-tau amyloid ratio, and total tau amyloid ratio. And we see this fairly stepwise increase in the proportion who were considered biomarker positive, with normal participants having the lowest proportions, and then increasing proportions of positivity among the early and late subtle cognitive decline folks, with the greatest proportions of positivity in the MCI group, as would be expected. And then next, here's a survival curve for the time to MCI diagnosis. And so the normal group is in, the cognitively normal group is in this light kind of bluish gray at the top. The early subtle cognitive decline group is the solid blue line, and then the late subtle cognitive decline group is the dark blue dotted line. And so what you can see is that the two subtle cognitive decline groups both progressed faster than the cognitively normal group, and that initially the late subtle cognitive decline group did progress faster, but the early group does seem to catch up over time. And so this was some of our initial hope that process scores did seem to be able to be successfully integrated into an operational definition of objective subtle cognitive decline, and did seem to improve the sensitivity and prognostic value of this classification. So going forward, we've now generally collapsed the early and late Objective-SCD criteria together. So I'll just talk about some of the work that we've done in applying these objective subtle cognitive decline criteria. So just on the right is a schematic about where we think the Objective-SCD classification falls on the Alzheimer's disease continuum. So in this preclinical phase, and again, prior to MCI and dementia. So for this first study, we examined 4-year rates of change in cortical floor beta pure PET, which is a ligand for measuring amyloid accumulation. We also looked at entorhinal cortex thickness and hippocampal volume, and those classified as objective subtle cognitive decline and MCI relative to cognitively normal participants. And so what we found is that amyloid accumulation was faster in the objective subtle cognitive decline group, so they're in kind of that teal color, than in the cognitively normal group. And also the MCI and the cognitively normal groups did not differ from one another. And then the objective subtle cognitive decline and MCI groups both demonstrated faster entorhinal cortex thinning relative to the cognitively normal group. But only the MCI group exhibited faster hippocampal atrophy than cognitively normal participants. So there was the beginning of a trend there for the objective subtle cognitive decline group as well. But what we think is interesting about these results is that they're quite consistent with the Braak neurofibrillary tangle staging scheme, and that objective subtle cognitive decline status may track with really early entorhinal pathologic changes, whereby MCI may track with more widespread medial temporal lobe change. And so again, we think the Objective-SCD classification may be a sensitive approach to identifying those at risk for encroaching amyloidosis and neurodegeneration. We have also examined cerebral blood flow in brain regions that are impacted early in Alzheimer's disease to see if there are differences in blood flow across, again, cognitively unimpaired, objective subtle cognitive decline, and MCI groups. And we found an increase in cerebral blood flow in the hippocampus and inferior parietal regions for the Objective-SCD group. So they're actually showing hyperperfusion relative to the cognitively unimpaired and MCI groups. And so this is a pattern that we see in people at risk for Alzheimer's disease, such as cognitively normal individuals who have an ApoE4 allele, for example. And what we think is going on is the increase in blood flow may reflect kind of the very early stages of neurovascular dysregulation. So higher cerebral blood flow is needed to maintain cognitive functioning relative to MCI participants, but is also reflective of some of the early cognitive inefficiencies that distinguish the objective subtle cognitive decline group from the cognitively unimpaired group. And then additionally, we've examined whether objective subtle cognitive decline predicts future functional decline as measured by the functional activities questionnaire, as well as whether objective subtle cognitive decline interacts with type 2 diabetes to predict functional decline. So on this graph, higher scores represent more functional difficulty, and we found that objective SCD, both with and without diabetes, so the maroon line and the blue lines, both have faster functional decline than those without objective subtle cognitive decline, but that the SCD and diabetes classifications interact to have an accelerated functional decline, which is shown by that maroon line there. And so just in terms of implications, so these objective SCD criteria do seem to be a non-invasive and cost-effective way of identifying people who are at risk for future declines. It's important, as Christina mentioned at the beginning, that it's non-invasive and that it doesn't require a procedure like a lumbar puncture or radioactive tracer. And we think there may be some uses for these criteria in terms of recruiting individuals for clinical trials. We also know that early detection allows for more opportunity for early intervention, perhaps with behavioral or vascular disease management interventions prior to the onset of cognitive impairment. And then neuropsychological tests are already administered in most aging studies, but aren't often analyzed as often as we think they should be, or even necessarily included in the diagnostic decision-making process. And then the process score information is almost always totally untouched. But these scores can be obtained without any additional burden to the participants. Now, there's a caveat: if the process scores are not already coded as part of the data entry, there will be some additional researcher burden there. But I think that this is a rich treasure trove of data that still need to be explored in a lot of studies. And then there's still a lot of work that needs to be done using the objective subtle cognitive decline classification. So this work has predominantly been done in ADNI, which is a very white and highly educated and very healthy sample of older adults. And so we really need to see whether the objective SCD criteria is appropriate for use in more representative and racial and ethnically diverse samples. So really, until this is done, these criteria are in the exploratory research phase and are not yet appropriate for clinical application. But we're hoping to do this work soon. And so I'm going to switch gears just a little bit to focus also on plasma, which is one of the areas of interest for my ADRC development grant. And so blood-based biomarkers for Alzheimer's disease have garnered a lot of attention given recent advances and availability of assays that will definitely yield more widespread availability of these plasma markers in the coming years. There's also the potential for plasma markers to overcome a number of the limitations associated with CSF and PET biomarkers, such as cost, access, medical contraindications, and has the potential to be a good screening tool or a good, possibly a good tool for disease monitoring. And so recently, my colleague, Dr. Katie Bangin, examined plasma neurofilament light, or NFL, and this is a marker of neuroaxonal damage. And she compared plasma NFL levels across cognitively normal, objective subtle cognitive decline, and MCI groups. And individuals with objective subtle cognitive decline and MCI both showed elevated plasma levels relative to the cognitively normal group. But these two groups didn't actually differ from one another. So it seems like NFL is changing quite early. And then across the sample, elevated NFL, which is just shown graphically on the right side just by a median split, elevated NFL predicted faster rates of cognitive decline. So within the objective SCD and MCI groups, higher NFL predicted faster rates of decline in memory relative to those with lower NFL, as well as a composite score of cognition, so the preclinical Alzheimer's composite. And so while NFL is clearly a sensitive marker for early cognitive changes, it's not a marker that's necessarily specific to Alzheimer's disease. And so for this next project, I focused on plasma phosphorylated tau 181. And recent work has demonstrated that plasma p-tau 181 does predict poor clinical outcomes. It does predict future neurodegeneration and is associated with both amyloid and tau biomarkers and neuropathology at autopsy. However, the timeline for when p-tau 181 changes is not necessarily known. And so for this study, these are the aims here on the left. So we examined plasma p-tau 181 levels at baseline and then looked at them longitudinally over 4 years by cognitive group. So cognitively unimpaired participants, again, objective SCD and MCI groups. And then as kind of a second part of this study, we looked at whether the combination of objective subtle cognitive decline plus elevated plasma p-tau 181 predicts faster changes in amyloid in Alzheimer's related outcomes. And so again, for this study, we used participants from the Alzheimer's Disease Neuroimaging Initiative. Participants were about 74 years old and highly educated, about 16 years, and again, were predominantly white. Important to note, there were no demographic differences across the diagnostic groups. And so cross-sectionally, cognitively normal and objective subtle cognitive decline groups had lower baseline plasma p-tau than the MCI group, and the cognitively unimpaired and objective SCD groups did not differ from one another. So this pattern is a little different than what we see in NFL, where the objective subtle cognitive decline group, it has levels more consistent with MCI. However, longitudinally, after adjusting for age, sex, ApoE, E4 frequency, and vascular risk, the objective SCD group in blue did have the steepest increase in plasma p-tau over the 4 years. It was the only group to differ from the cognitively unimpaired participants. So again, just highlighting these quick results, the plasma p-tau didn't differ between the cognitively unimpaired and objective SCD groups at baseline, but longitudinally, the objective SCD groups did have the faster increase in p-tau. And so despite kind of this long-held assumption that cognitive changes do always follow biomarker changes as depicted in these well-known Jack curves, these findings, along with some of our other work, suggest that early neuropsychological difficulties may emerge before or in tandem with some of the measurable changes, especially in plasma markers. And so as a second part of this study, we classified participants as p-tau positive or negative using a threshold derived from predicting explored tau-superior PET positivity within ADNI. And then 4-year changes in amyloid PET, global cognition, and everyday functioning were examined by group. And on the left here is the amyloid PET chart. So only the Objective-SCD plus p-tau positive group in green there was associated with a faster increase in amyloid over 4 years. And then on the right, for cognition here, we use the preclinical Alzheimer's cognitive composite because this measure was independent of the scores that we use to classify the Objective-SCD group. And again, what we see is the combined Objective-SCD p-tau positive group in green definitely shows a faster decline in cognition. We also examined 2 measures of everyday functioning. Again, the functional activities questionnaire and the CDR sum of boxes. And both measures showed faster rates of functional difficulty, so higher is worse, in the Objective-SCD p-tau positive group. Again, despite there being really minimal functional difficulties at baseline. And so for the second aim, when combining the cognitive classification with p-tau positivity classification, that combined Objective-SCD plus elevated plasma p-tau showed the fastest increase in cortical amyloid on PET, fastest decline in cognition, and fastest increases in functional difficulty over 4 years. And again, the non-invasive nature of both methods may increase our ability to assess biomarker changes and Alzheimer's disease trajectories in larger and more representative samples, given the potential for greater accessibility than PET and CSF. So now I'm just gonna switch gears for a minute. I've begun to investigate the relationships between plasma biomarkers that are recently available within the ADRC data and their relationship with comprehensive neuropsych tests. And so within the ADRC, we now have several plasma markers available on a subset of participants who have gone to autopsy. And so the plasma markers that are available include amyloid 40 and 42, p-tau 181 and 231, total tau, and neurofilament light, or NFL. And so the markers that I use, so amyloid, the ratio of amyloid 42 to 40 seems to be the most promising measure of amyloid using plasma data. And then both measures of p-tau do seem to map onto both amyloid and tau pathologies. Total tau, while it's available, is a bit nonspecific and as a result really hasn't shown much promise in Alzheimer's disease. And then NFL, as I mentioned before, is this marker of neuroaxonal damage that is definitely elevated in Alzheimer's disease, but is also elevated in a lot of other neurodegenerative disorders. And so here are just some basic demographics from the first available blood draw that people had. So again, everyone in this sample has gone to autopsy, so the sample is maybe a little bit older. Dementia participants were about 5 to 7 years younger than the cognitively normal and MCI participants. And MCI and dementia participants tended to have more males and more ApoE4 carriers, less time to death, and fewer participants with low pathologies at autopsy. And then the cognitively normal and MCI participants, as expected, performed better on the MMSE and the DRS than the dementia group. Again, and also just notice that there were definitely many more dementia participants than people in the cognitively normal or MCI groups. So just looking quickly at the plasma levels by group. So for amyloid 4240, p-tau 231, and p-tau 181, cognitively normal participants had better levels than both MCI and dementia, and MCI and dementia didn't differ from one another. For NFL, the cognitively normal and MCI groups didn't differ from one another, but the cognitively normal group had lower levels than dementia, and then the MCI and dementia groups didn't differ. And then for total tau, there were no differences in level by clinical classification. And so these are the aims that I had proposed for my development grant. So I'll just talk a little bit about some preliminary analyses using the neuropsych measures for aim 1. And so to start, I ran some general linear models looking at the relationship between each plasma marker and neuropsychological measures. And so all the models that I'll show included age, sex, education, ApoE4 carrier status, cognitive group, and then the visit number of the plasma data as covariates. And so then I also added a cognitive group by plasma marker interaction to test whether the associations between the plasma marker and cognition varied by degree of cognitive impairment. And so just jumping into some of these preliminary results, the relationship between amyloid 42 and 4240 and cognition was really limited to memory performance on logical memory. So the higher the ratio, the better the memory performance. And none of these relationships between amyloid and neuropsychological measures were moderated by cognitive group or cognitive diagnosis. Now for plasma p-tau231, higher levels were associated with poorer memory performance across several measures, as well as poorer trails B and BNT performances. And also there was a moderating effect of cognitive group. So relative to dementia, which is the maroon line, the cognitively normal group in blue had a stronger negative relationship between plasma p-tau231 and measures on the CVLT, as well as category fluency. So notably, these are some of the two more sensitive measures for early Alzheimer's disease. So it's kind of interesting to see the relationship with plasma p-tau be strongest in the cognitively normal participants. And this pattern was really very consistent across most of the CVLT indices, including learning trials 1 through 5, short delay queued and long delay queued recall. So it was a pretty consistent pattern. Now for plasma p-tau181, higher levels were associated with poorer memory performance only, though the patterns were similar for the other measures. And for p-tau181, cognitive diagnosis did not moderate any of these relationships, though a pattern is similar to what we saw in p-tau231 for the CVLT scores was trending, but not significant. For total tau, again, this doesn't seem to be very related to cognition. So there were no significant relationships with the neuropsych measures, and cognitive diagnosis did not moderate any relationships. And then finally, for plasma neurofilament light, higher levels of NFL were associated with poorer letter fluency performance. And cognitive diagnosis did moderate some relationships here. So relative to dementia, the cognitively normal group, again in blue, had a stronger negative relationship between plasma NFL and CVLT immediate recall and long delayed free recall. So again, the higher the NFL, the lower the memory performance. And so the pattern for plasma p-tau, especially 231, as well as NFL, is that there seems to be the stronger relationship with cognition in those participants who are still in the cognitively normal range, suggesting that maybe these biomarkers are changing that early. And one other possible limitation is that since most of the participants did have dementia, it's possible that for some of these really sensitive markers, they're actually hitting a floor level. So there's just not as much variability when participants with dementia are recalling like 0 or 1 items on the CBLT, for example. But we definitely plan to explore that a little further. And then what I found exciting is it's these sensitive measures like CVLT and fluency tests that had the most consistent relationships with plasma markers, especially p-tau. And then there are a number of future directions. So I would like to see whether plasma, p-tau, and NFL markers are especially predictive in those cognitively normal participants who go on to progress to MCI or dementia. And we're working right now to identify those individuals and who has those plasma data. We are planning to send some more samples to be processed. So I'm really excited about that piece. I'd like to develop a method for using some of the plasma markers together as a profile kind of similar to the ATN profile. So if someone's amyloid positive or negative, tau positive or negative, neurodegeneration positive or negative. I think that could be interesting as a way to, since going forward, it's likely that you won't just have one of these plasma markers, you'll have a couple to see if there's value in looking at some of them together. And so this may be a little bit difficult in this sample, and it might be more useful in, again, the cognitively normal participants, since most of these individuals did have Alzheimer's pathology and so did have elevated amyloid, making it difficult to really tease that apart in an ATN model. Amyloid might not be very helpful if everyone's positive. I plan to run some similar analyses at the last ADRC visit. So these were the participants' first blood draw, but we do have the longitudinal data. So I'd be curious to look at whether the primary pathology moderates some of the relationships with cognition at their last visit. And then, of course, looking at these relationships longitudinally, which we can do with this really rich data that we have available. So I think that's all I had. I'm definitely happy to take questions. A lot of this stuff is still a work in progress. So I appreciate everyone tuning in.